Hello and a warm welcome to the CNBC Africa special in partnership with Philips. Today's conversation will be based on new research that has been conducted by Philips called the Future Healthcare Index, which takes a look at a country's perceived readiness when it comes to achieving an integrated healthcare system. We'll take a look at the results, which do show that South Africa does rank number 8 out of 13 countries. And with our panelists joining us here today, together with our esteemed guests who are respective stakeholders within the healthcare fraternity in South Africa, we'll find out how we can path a way forward and take a look at the reforms and policies that need to be implemented to ensure that South Africa does achieve an integrated healthcare system by the year 2030. I'd like us to welcome my panelists who will be joining us for this conversation, starting to my left with the Honourable Minister of Health within the Republic of South Africa, Dr. Motsoaledi. Thank you so much, sir, and welcome. He's followed by the Chief Executive of Philips South and Southern Africa, Ndudule Tsenye. Thank you so much, sir. Followed by the Health Editor for the Mail and Guardian, Mia Malan. Pleasure to have you with us, ma'am. And lastly, at the end of the panel is the Chief Executive of the Hospital Association of South Africa, Dr. Dumisani Bomela. Thank you so much for your time, sir. As mentioned again, our audience is also present with us here today and will be participating in conversation with us, sharing their thoughts, insights, and analysis as we chart our way forward to an integrated healthcare system here in South Africa. Honourable Minister, I'd like us to begin by starting off with you and getting your opening remarks with regard to what you highlighted very briefly today in your opening address when you addressed the audience here. And clearly you mentioned that the bedrock of South Africa's healthcare system is based on two plans which we will not deviate from. The National Development Plan, together with the objectives of the Sustainable Development Goals. Having painted the backdrop of the Future Healthcare Index, which does show that South Africa has its challenges, has its opportunities, but for the moment can certainly perform a lot better than its peers, how do you respond to these two plans that we have in place at the moment and how we can progress given the foundation that's been set by the Future Health Index?
Well, look, as I have said, I've outlined the two major plans that we're following. As I said, the National Development Plan and the United Nations 17 Sustainable Development Goals. They look very similar, actually, despite the fact that the National Development Plan was designed here in South Africa and predates the 17 Sustainable Development Goals of United Nations by at least 3 years, but they look very, very, very similar. And that makes me very comfortable. The findings here are a reflection of quite a number of things, as I said, which we already know about. In other words, I don't want to undermine them, but I just want to say it's just a reflection of what we already know. They were just putting it in more clearer scientific terms. So there's no way I could challenge them. But just to mention that I looked at the spectrum of the countries, the 13 countries, and why South Africa is put at number 8 out of that 13. If you look at those 13 countries, with the exception of Brazil, South Africa is a clear outlier in most of them because our healthcare system is 2 countries in one. Yes, those countries have got one healthcare system. We have got 2 healthcare systems, which resemble 2 countries in one. One country in Europe, the other here in Africa. That's exactly what we are dealing with. And so for that reason, we have got a bigger job than all those countries. And that's why we're having those problems. If you look at, I don't know all the countries he has mentioned, but the ones he has given an example, yes, the ones Tuntulu has given an example about. For instance, he says we are spending 9% of our gross domestic product on health. Yeah. That's the average for Europe. That's the average for Europe.
So then would the question be, why don't we have healthcare system which is of the same quality?
Precisely the point. That's very brilliant, actually, for you to have noticed that.
Because I'd appreciate that in my performance appraisal, Minister.
It is quite brilliant for you to notice that. Because Europe is at 9% and we're already there, but with completely different outcomes. Within BRICS, the only country which is at our level is Brazil. They are also at 9%, but they've got better outcomes. The other countries in BRICS are still far from that 9%. China is still at 4.6%, India at 4.2%, Russia at 5.4%. But all of them have better outcomes than us. So the brilliant observation you've made is why. Extreme inequality. It's extreme inequality because the manner in which the money is divided in the population is that much more than half of that, much more than half of that, serves only 16% of the population, and the remainder goes to 84% of the population. That gross inequality is unacceptable. That's what Alma Ata declared in 1978, that the gross inequality between developed and developing countries, but even within countries, is unacceptable, whether you look at it politically or socially or economically. And that is what we are dealing with. That is why we are saying our solution in NHI is not far-fetched. Many people believe NHI is designed to kill the private healthcare sector. I've repeated that I don't know how many million times, that that's not the aim. It's not anywhere, there's no plan anywhere. We want to use both systems. We want them to be available to the whole population in an integrated manner. There's no reason to live in two different countries in one. We want to live in one country, and we believe through a system of national health insurance, by pooling funds for the whole population, we'll be able to achieve that. Then when you do that study again, you'll come to different conclusions. If you do it after we have integrated the system in pooling of funds for the whole population, rather than dividing the population into two different countries.
I think that there are several concerns that are highlighted with regard to the NHI and the white paper that was recently released. Mia, I'd like to come to you very briefly here, sir, and I do understand, ma'am, and I do understand that the concerns here with regard to the administration and the actual role that the private sector will play. Minister, I'm not too sure if you are at liberty at the moment to provide us with a brief outlook and an update as to whether or not there's further clarity on that. But if not, then Mia, I'd like you to follow up perhaps by painting a picture of some of the concerns here with this very positive idea which will have a positive outcome for the whole population, but some of the key areas of concerns, especially from the private sector. Mia, go ahead. Yes. Dr. Bomela, please feel free to join us in as well.
Well, I think Dr. Motsoaledi is absolutely right that universal access to healthcare is a World Health Organization goal and it's a sustainable development goal. So that is where our country should be moving towards, and we really do have a very unequal system. We have 16% of this country that can afford medical insurance, and the rest of the country is either reliable on the public healthcare system or they pay out of pocket for private healthcare. I think the National Health Insurance Scheme, that most people agree that it's a really ambitious and a good goal, but everyone doesn't agree about the state of readiness for the country, and I'm sure Dr. Motsoaledi has heard many of those arguments. So we have national health insurance pilot districts in the country, and there have been concerns. So those are districts where the health department tries to allocate resources to and it's very poorly resourced districts, to try and build up the system as an example of what can be done in the National Health Insurance Scheme. And there have been concerns that not a lot of progress have been made in those pilot sites. Of course, there has been progress, but there are a lot of concerns that the hospitals have not sufficiently and the clinics been upgraded. One of the concerns of the private sectors, or the questions that the private sector have, is how will they be involved in this scheme? Now, Dr. Motsoaledi has often pointed out that the private sector is really expensive and is unaffordable at its current price structures for the national health insurance to buy those services at those prices. But I think one of the fears and the confusion in the private sector is, because the National Health Insurance Scheme will basically be a scheme that administers funds, more money for healthcare. The medical aid scheme industry wants to know how will it be involved? Will it be able to help to administer those funds? And I think they're quite concerned that those details are not really contained in the white paper that was released last year. And the private health industry feels that they can help to properly administer funds and want to know, is the government going to administer it themselves, or could they help? So for instance, would private doctors be paid in time, and how much will they be paid? And it will definitely, from what I understand, be a different structure. At the moment, GPs are paid a service for a fee. So you go and see a patient and you pay, you see a doctor and you pay for that time. But in a public healthcare system, it generally will work differently. It will be salary, right? And it will be based on how many patients, what the health profile of that district is. So I think there are many questions around it, and I think it's questions that will take some time to answer.
Minister, I'm not too sure if you want to respond very briefly before Dr. Bomela also engages, because the key question as well will be the buy-in and the level of interaction that we have
let him
with the private
engage, because
sector.
I'm sure they are going to raise more or less the same things.
Dr. Bomela, would you?
Yes.
I think clearly the future of healthcare does link up with what has been articulated by government as policy, which is the universal healthcare. And the objective is to try and attain equity. And I don't think anyone in their right, in their right frame of mind would argue with that. So what has concerned a lot of observers is the fact that things are stated at this point in general terms. And because of that, everyone is beginning now to construct their own end game. What is it going to look like for my role? If I'm a private hospital, if I'm a medical scheme, people are beginning to construct that in their minds and are advancing arguments based on those constructs. From the private sector standpoint, the big issue is that we don't have health professionals. And, you know, we just have nothing to redistribute, even if we were to redistribute. And we just see a need for a very concerted effort towards increasing the human resources as in the health professionals. And, you know, you look all around, we have a shortage everywhere: doctors, specialist doctors, nurses, and the various other allied health professionals. Now, these people are required to service, to man and service the delivery platform that is envisaged in future healthcare. It's a concern, and I think I speak for most people when I say that our view is that something has to be done now out of the ordinary to try and address that. In other countries similar to ours, in terms of where they stand on the income levels, higher middle income countries such as Thailand, you find that the way they dealt with it, there was a country cooperation strategy that sort of helped in the planning and coordination of the system as it was brought into place. And it didn't take them a long time. The policy only came through in 2002, and they are already talking about access for the population in the region of the 90s. So in terms of dealing with this, which I think is a ticking time bomb for any future healthcare system in South Africa, healthcare arrangement in South Africa, the human resource side, I think the important thing is that we have wealth of expertise, experience, of having by various players within the system. And therefore, we also do need this open cooperation and consultation all the way through.
Precisely, which is what I'm hoping that we'll try to get into in the moment in the conversation, because there are many elements that have been highlighted. You mentioned the skills in HR, which we will delve into a little bit later, the cost elements as well. How are we going to manage to pool all these funds together when we know that the macroeconomic conditions facing South Africa at the moment are under significant strain? If I'm not mistaken, I think some of the estimates were based on GDP growth of upwards of 3%, and we know the reality in South Africa is that we're facing a challenge where we saw a retraction in growth in the first quarter. But I want us to draw some solutions and some engagement from members of the audience as well. But before we get to them, with regard to some of the conversations that need to take place and what they would like to have the government engage with them on. Minister, you can respond very briefly.
Yeah.
And Tutula, I'm hoping that we can also come to you
Yes.
to get your
Well,
thoughts
yes,
on
yes,
what we need to
yes.
engage on. Then we'll come to the audience very briefly as we're still on the topic of NHI to share their views on what it is that we do need to focus on
Yes.
when it comes to engagement.
Let me respond first on the issue of human resources. I'm quite disappointed that time and again it is being used as a reason why we're not ready for NHI or universal health coverage, when actually it's the other way around. Number one, I don't agree with Dr. Bomera that we've got nothing to, well, he used the word distribute. We are not asking them to distribute anything, we just want to share. And I don't agree with you that we have got nothing to share. 20% of the specialists of this country are saving 16% of the population. That's the reality. Leaving only 20% of the specialists to deal with 84% of the population. Surely we can do better than that. Countries are not run like that.
I think Dr. Bomela was also alluding to the fact that we do need to develop from a grassroots level and make sure that the skills are there to
I'm coming
address
to
the
that.
masses that will come.
I am coming to that, but
Okay,
I'm
Minister.
giving you what we have already. That even what we have, we are not sharing enough. Even the little that we have got, that's the reality. Now, let me give you this example. I spoke about school health. We've got 12 million kids at school in South Africa. And we don't know exactly what they're suffering from, what their problems are, etc. So we went in there and we said we must do 5 things at schools. One of them being physical barriers to learning. What are those things that will make it impossible for a child to learn and achieve their goals in life? Physical barriers to learning are simple things. We identified 3. Eyesight. How many kids can see very well? And who can solve that? Hearing. How many can hear well? And oral hygiene, speech, that affect their speech. We have screened 900,000 in Quintile 1 and 2 schools. Quintile 1 and 2 schools are the poorest in the country. In other words, the children who attend there are not part of this 16% who have got access to specialists. We have screened 900,000 of them. And guess what? 1/3 have got either of these 3 problems. Either they've got a problem of eyesight or hearing or speech. In fact, the highest number, those which have got problems of oral hygiene. Again, highlighting the thing of sugar, you know. A lot of kids are destroyed in their mouth because of that. Now, what am I leading to? They need an audiologist. They need a speech therapist. They need an optometrist.
So we need more of those to be rolled out on the ground.
No, those I'm talking about will never find them in the public sector. They are in the private sector. Should I sit here and fold my arms and say, I know kids who cannot hear, who cannot see, whose speech is not perfect, and I can't help them, and 12 years later we're expecting them to write matric? Surely I must use the specialists there in the private sector. That's what we want to do in NHI. I must be able to contract them. As it is at the moment, under the present platform, is going to be extremely expensive, if not something that is unreachable. Basically, that's what we mean by sort of sharing. We are now having Nelson Mandela Children's Hospital, built under the name of Madiba. We were looking at the broad range of specialists who are going to run that hospital. Believe you me, if we don't share, we'll never be able to run that hospital. Because the number of pediatricians in specialties are very few in the country. The second thing I want to say, by the way, this issue of the health workforce, which, by the way, is one of the 6 building blocks of a healthcare system according to a World Health Organization, it's not a South African phenomenon, it's a world phenomenon. We discuss it every year at the World Health Assembly. Presently, there's a shortage of 4 million health workers around the world. By 2050, the shortage will be 40 million and 18 million in the developed countries. That's why the Secretary General of the United Nations has set up a special commission on this issue. That commission called Health, Employment, and Economic Growth, which is co-chaired by President Francois Hollande of France and President Zuma, is to solve this issue. They are saying that the shortage of health workers around the world is becoming critical. The difference is that we are in sub-Saharan Africa, which has been declared a crisis region in terms of this shortage. But it's global. That is why even rich countries like United States itself, they're still recruiting doctors from us. Australia is, the Middle East, Britain, we even have to negotiate with them and say, ceasefire, please, it's too much.
Minister,
It was discussed at the level of Commonwealth. So what he's describing is not a South African phenomenon, it's a world phenomenon, and I don't see why it must stop South Africa moving towards NHI when it could not stop the other nations who have got a similar problem.
So let's source these solutions, Minister, and I'd like to ask it in a multifaceted manner to giving both Ntutule, Dr. Bomela, as well as the audience members an opportunity to interact here. Ntutule, this is where I'd like you to come in, perhaps where in sourcing these solutions, is technology the enabler where we get more optometrists, more audiologists out there on the field making use of these technologies, integrating them with the larger system to ensure that these services can be reached? Dr. Bomela, I'd like to give you an opportunity as well just to respond with regard to your view on the level of skills and training and development. As we do know, on a national level, we do often see an exchange of skills significantly with countries like Cuba. And for the audience members here, who are those representatives who work in the private sector and don't have as much exposure to the public sector, what will it take to get your encouragement and your involvement in the public sector that you'd like perhaps to engage the government on? If Ntutule and Dr. Bomela kindly respond.
I think the whole disparity between, public and private, the 84%, 16% split and, sharing similar resources, obviously it's a disturbing one that I think everyone in this room would be worried about in just making sure that we can close that gap. But I think as a technology solution provider, as Philips, I don't think we are running short of innovations out there. I think I've spoken about some of these things that are really saving lives, whether it's at the primary health, whether it's within your normal, hospital system, secondary, tertiary. So I think there's a lot of that. I think what I would like to see more, also listening to the conversation, is really more opportunities for co-creation. I don't think that is happening a lot, especially between the various types of suppliers, whether it's technology suppliers, innovation suppliers, and government and other stakeholders. I would like to see more effective opportunities around, public-private partnerships, where not only, today, for example, if you look at technology supply, today the interaction with governments to a large extent is through a tender where there's again, boxes that need to be pushed. But I think it's important that perhaps the providers of these solutions can sit also with government just to make sure that we've got very good co-creation opportunities, global companies that are best practices elsewhere that we should be able to share and all of that. And I think in small areas where we've been able to do that, you can see that there's some traction that is actually coming out of that. And I think out of that, we need to go beyond that and start looking also at saying, when we engage with these private public entities, can we also be co-accountable for the outputs and the outcomes of this healthcare as well? Because I think sometimes, one party just brings one element, which is just small part of the whole pie, and then they move out. But I think we can get an opportunity there again, where we do these things together. So I think there's an opportunity there.
Dr. Bomela, very briefly, your response again with regard to the skills and level of development and exchange here, and again, justifying the pressures that you alluded to with regard to skill shortage.
Clearly, technology has got a crucial role to play, and it's a great enabler in healthcare, as it is with many other things. And when you talk about connected health and all of those that have already been described earlier on today, the issue, though, is that healthcare is essentially a contact sport. You have to encounter either the professional or the institution, the institutional provider, as a patient in order for you to have received the service. And now, once you have, if you don't have the critical mass, you're just gonna have an uphill battle. So the high-level goal should be that of increasing the number, the pool. The issue of how that pool is distributed within the health system is another question for another day, but now you have that discussion at a later stage when you already have the pool and you can make those choices. The fact of the severe shortage that is getting worse now is actually robbing the health system of those choices. So the goal, as we see it, should be for a massively increased production. We need to increase the production line. How that is done is for the stakeholders within the health system to share ideas and craft a mechanism of doing that. We have countries around the world that have been able to retain what they produce, and India being, in relative terms, being an example of those. And
How do
we
we
have
implement the successes that they've gained in the South African perspective, from your view?
the important thing is to have the goal as the guide to the debate and to redirect the debate towards that goal. If you look at a country like Malaysia in the mid-1990s, they had a massive shortage of, I'll make an example with doctors, a massive shortage of doctors, just like we have now. 13 years later, they had an oversupply simply because they had this high-level objective that they then implemented, and that was internal production. They didn't import. So if I look at the NDP 2030 being about 14 years ahead of us, I think by 2030, if that debate was happening in earnest and meaningfully right now, we will, in the beginning, we will struggle to be able to supply the health professionals, the health facilities, and resources to the entire population. But at a point in time, we will get more and more able and comfortable in doing what is required by the system.
More on the state of healthcare in South Africa after the break.
Let's start off with your questions, sir. Then we'll come to the gentleman over here. And there was another hand towards the back, so we'll take 3 questions. Go ahead, sir.
Thank you. My name is Howard Manyonga. I'm an obstetrician gynecologist working in the area of designing health systems that increase access to women for preventive services and maternity in the private sector. Now, mine is a comment and a question. Although the specialists are there, we are using them inappropriately. So in my own area of women's health, there is no reason for me as a gynecologist to go and deliver a normal baby. And one of the barriers in the why specialists in the private sector are working like that is partly a fee-for-service structure that we have in our system. Secondly, perhaps there is the fear of the medical legal consequences arising from complications during childbirth. Now, Dr. Bumela, would you agree with me when I say that the way that the hospital association members, the private sector, work and make their money runs counter to the principles of applying primary-based care in women's health, for instance, starting with midwifery care to GP care, eventually to specialists, that our specialists are tied down in menial work when they should be concentrating on first-order problems, which are complicated cases and so on and so forth. Has there been any progress made in looking at the regulations around the payouts and the rate of increase of the medical legal risks to to those working in the system, because this is a major barrier for us trying to innovate, to bring in lower level workers, to bring in task shifting in the private sector, that the midwives and nurses are not indemnifiable, as it were, under the current systems, and there is need for reform in that area. Thank you.
Thank you so much for your question, sir. We'll go ahead with our second question here.
I'm Nicholas Dunius from a small private company called Altus Biologics. And I've got one very quick comment to say is that we've had a very positive experience the past 12 years in a public-private academic partnership, the so-called triple helix of cooperation. And it resulted in the generation of the Center for Tissue Engineering, which has been an effort of all three collaborators. And to date, the center produced sufficient bone grafts from donors to treat more than 40,000 patients. These bone grafts are produced at a fraction of the imported products. The Department of Science and Technology has gone further to fund my company to commercialize a humanized porcine bone graft, and it's being made available at 1/5 of the price of the imported product. So my question is, we have an example here of a very well-priced medical device, bone grafting medical device. It's a free market system, so whoever knocks on the door, they can get the product available. But what we're finding is that our invoices get paid very, very quickly by the hospitals. They've got very good systems. They pay at 30 days on time, perfectly on the 25th. As the clock strikes 12, 1 minute past 12, the money's in the bank. But unfortunately, in the private system, it's not happening. You know, we have to do a lot of PT and work and running after the accounts departments. So that's my comment, and my question is, can we remedy something like that to try and get everything turning better in the public sector that will improve the situations?
Thank you so much for your question there, sir. Nicholas, what we'll do is that Dr. Bomela, if you could perhaps respond to the three areas that were raised with regard to your particular area of interest, if I'm not mistaken, the costing structure and the fees there, and of course, naturally, are there lessons perhaps, and would your organization be flexible enough to assist the government in managing and learning lessons with regard to the payment system that's been alluded to by Nicholas? Very briefly, sir.
I think the question that was directed to me was by the gynecologist. I think the behavior of the various players within the system is a product of the incentives that are existing within the system. And one of the things that are becoming apparent within our South African health system as we move towards universal health goals is that the various pieces of regulation, legislation, and policy are not well coordinated. They came about in a fragmented way, well intended in their own right, but with unintended consequences to the system at large. And this lack of coordination within the environment has failed the system in that the system, unlike it does in other countries, you are able to influence provider behavior and the behavior of other players through incentives that are created by the system. And I think the examples that have been advanced are in fact another symptom of that. And hence, we think that in 10 years' time, 20, 30 years' time, we'll still be sitting discussing these things if we don't have this collaborative effort up front that identified the key high-level goals that we must all work towards.
Dr. Bomela, perhaps the Minister would like to respond very briefly to that, as well as provide perspective with regard to some of the other areas and questions that were raised.
I'm not sure whether I understood the response, because what the doctor there was asking was about the fee model, which we are worried about, the fee for service model presently being levied in private healthcare in South Africa as a perverse incentive. And I want to say this issue has been discussed worldwide. There are many methods of payment, including fee for service, including capitation, including, there are about 4 sort of different type of models. One that is not working is fee for service. But countries did not choose the others. They choose a combination. If you use purely a fee for service model, there are no amounts of incentives that can improve the system. It's just a perverse incentive by itself. So we are studying combinations of many number of models. As part of the piloting, we are already piloting that. We are already investigating that in the 10 central hospitals. The diagnostic-related group, which are called DHCs, where a group of diseases are grouped together and charged as a group for a particular fee. The example I gave, for instance, about school kids who have got problems of eyesight, hearing, and oral hygiene, who need speech therapists, etc. We're not going to contract them on a fee-for-service basis. We will tell them that you are a group of audiologists. We want you to take care of these 100 schools every year. Screen the kids there, and this is how much we'll pay you. That if we start doing it fee-for-service, it's going to be a perverse incentive. You can as well close shop. It's not going to happen. Because that is the model that is destroying healthcare in our country. The second area you raised, Doctor, litigation. I'm not surprised as a gynecologist because we are the biggest victims for that. Yes, it's a topic for another day, but it's destroying the healthcare system, especially in the private sector. Because it's again another perverse thing, unfortunately, by lawyers who get angry when I mention it. A few years ago, they didn't care what happens in a hospital because they were getting a lot of money from the road accident fund until it got bankrupted. Yes, when it got bankrupted, they changed the rules and tightened. And I remember even writing an affidavit to help them in court. I was not aware that after winning. Because yes, I wrote an affidavit to the Minister of Transport to help them about changing the rules in the way road accident fund function. Immediately after those rules were tightened, lawyers found their way into hospital. In other words, they were using the road accident fund as a gold mine. Unfortunately, I have to use those words. When that gold mine was closed down, they found another gold mine among doctors. And prime in that group are gynecologists. They are litigating them like it has never happened before. Because they know if you are a gynecologist, the chances of making a mistake are always high. So they are actually going away, even in the private sector. One of them is this gentleman here in front who have just spoken. He announced a month ago that he's leaving. So what gynecologists are doing in South Africa? They are no longer practicing obstetrics. They practice on gyne because gynecology is disease of women. Obstetrics is pregnancy and childbirth. So we have reached a situation where a woman is attending to a particular gynecologist for 10 years. One day she comes pregnant. And the gynecologist said, no, I'm sorry, I'm no longer your doctor. Go to look for somebody else. But why? Because when you are pregnant, you are now a bombshell, you are a danger. And now we can't have that type of country. You ask exactly what's happening. We had that summit. And the summit concluded that we must have 3 responses to this. First of all, the medical part. Let's not deny that mistakes do happen, but let's lessen them. And that's what we are working on. We even have a task team consisting of retired judges, lawyers, doctors, and specialists. It's a task team that I've just formed a month ago who are advising me on those issues. The second is administrative. If the gynecologist has done wrong, what's wrong with accepting and deal directly with the patient? The last one is changing the rules. The perverse incentive the lawyers are doing is what is called contingency, where they are not paid a fee. You just sign a form and they say whatever money you get from the state or from the doctor, we're going to share. unfortunately, I don't know who's American here. I'm not talking ill of Americans. It's a perverse American system. Europe is no longer used it. In fact, I've been warned by the Director General of the World Organization, Dr. Margaret Chan. She said that contingency is one of the worst that America bequeathed to the world. Please do away with it, because the rest of the world is doing away with it. If we don't do away with it, doctors will suffer. So we are busy with that, and it's still in the beginning, but I just want to assure you that we want to resolve it.
Minister, very briefly, there was also a response, but I will come to you for that with regard to some of the responses from the questions that you had before we start wrapping up the conversation.
I have a comment on the gynecological issue. I recently did a story about a private gynecologist who had to close down practice. Her income was 250,000 rands a month. Her insurance alone was 45,000 rands a month. Yes. And from the income, she still had to pay the rent of her offices. And she's closed down now, and I've done a story about several private gynecologists that have closed down shop because they can't afford the insurance any longer. But I have a question for Dr. Motsoaledi. As a journalist, I've often wondered, so if you want a private doctor who gets an income of probably 300,000 rands a month, that's what they make, and you want that doctor to now work in a less resource system, and you want to pay them in a different way, in a way where there are more morals involved. It's like, improving the health of a population and not just of a per patient. How do you do that? How do you keep that doctor in that system? Because that doctor is certainly going to lose money, and is the satisfactory feeling of helping a population going to make up for that?
Well, Mia, the problem is what you are saying is happening under a wrong system. It's a completely wrong platform of healthcare, what's happening now. We are proposing that model in NHI, which is going to be a completely new platform. Because if you look at the white paper on NHI, the first paragraph is a definition of what NHI is. The second paragraph clearly says NHI is a substantial policy shift that will need a massive reorganization of the healthcare system, both public and private. That word massive means we are going to change everything as it exists now. Because, for instance, you are talking about paying a doctor less when, for instance, he's already paying 45,000 rand a month for insurance. In fact, it's not 45,000, 65. And it was not always like that. 8 years ago, it was 11,000 per month for a gynecologist. 8 years ago. Now, next, I know it per year. This year, I'm sure it's about 65,000. Yes.
Now, and next year it's going to be 88,000.
Yes.
88,000.
Which means it's more than 800,000 rand a month. No doctor can pay that. Now, you can't peg the healthcare system on that because it's very perverse. It was caused by what I've just described. A very bad system where lawyers are finding a mine in hospitals or among doctors. Now, we need to solve that because that's not what gynecologists should pay. Because I agree with you, Mia. The person who's paying for that is the patient. In fact, if you check at the American system, why America is the only country that's already spending 18% of their GDP on health, when on average Europe is still at 9%. It's because of this litigation, where doctors are no longer doing what the doctor is trained for. When you enter a doctor's, as a woman, I'm warning you, because of the present system, if you get into a gynecologist, most of the things he's going to do to you is not what you need. It's what the lawyer is going to need. He's going to do whole sorts of a battery of tests on you and investigation just to build a file in case he's asked that in court. And that you are paying. Yes. And then he's also going to charge you to pay for this 800,000 rand to pay for insurance. So it's a very perverse, bad system. If we peg the NHI on that and say we are paying doctors less, then we'll of course conclude that NHI is not going to work. I've heard people saying that many times. The second abnormality, Mia, is the PMBs, the prescribed minimum benefits. It's not, we shouldn't be running our health system like that. And I had people calculating the cost of NHI on PMBs. It's like me asking you, I want to take school kids to Durban, but it's very far, I want them to fly. Can you calculate how much is it? You go and calculate it on a first class, not even business class, first class seat, and say this is how it will cost to take the school kids to Durban. It's unrealistic, but that's what is happening now. They take that first class seat and say this is what NHI is going to be. And that is not what we are planning. So most of these perverse incentives, etc., if we read the NHI white paper, in that massive reorganization, we are going to have to do away with them. In other words, it's not going to be like the progress of NHI from where we are. It's not like it's going to be like metamorphosis from larva, which is a worm, to a butterfly, which is a different animal altogether. So NHI is not just going to be a bigger, fatter worm than the larva. It's going to be a butterfly, which is completely something different from what we have now.
Minister?
And we want that to be understood.
Due to the time pressures that we do have, I do want to start getting the closing comments, but we cannot forget Tandiwe and Nicholas's question. The question regarding occupational health workers, where do they fit with regard to the system, and not forgetting the management of finances. The private sector gets it right in administrating costs when it comes to public-private models in the academic perspective. In the public sector, how do we fast-track this? And I'd like us to perhaps give you an opportunity to think about that and include it in your closing remarks as we work our way down the panel to really commit to elements of this new movement from a larva to a butterfly, what it is that the hospitals, what it is that, Mia, from your perspective as an independent observer, that both the private sector and public sector can respond to, and Philips as well as a multinational player with keen interests in helping establish the health fraternity across the continent. What are the three main commitments and quick wins that we can ensure we implement to ensure the sustainability, the scalability, as well as leapfrogging certain elements with regard to this development? Perhaps if you can give us your views on one particular element that the hospitals are open to communicating with, engaging with, and really assisting in transforming the healthcare fraternity. Dr. Bomela, we'll begin with you, working our way down the line as we get to the Minister.
It has been indicated by Minister that the performance of the health system requires some drastic changes. I think the issue that will change the game, there's a few big issues that we need to be focusing on. We need to be focusing on promoting integrated care. We need also to be looking at the creating the correct incentives for players within the health system. And that can be done through various forms and policies that ultimately define the environment that we practice and access our healthcare from. But what I started with, I think if it is not addressed, it does undermine each and every effort that we might be looking at in fixing our health system.
What can the Hospitals Association commit to? Perhaps a positive skills exchange when it comes to managing finances?
What we are all about is about collaboration, something that hasn't happened in the past, both in the functional aspect of the system, which is the clinical service delivery platform, as well as the administrative aspects. We have evolved through experiential learning and expertise that has come through having run the institutions that we run in the private sector. And we really would like to get into a serious dialogue with other players in the private sector, the NGO sector, to really share what we think should be valued and is going to be helpful in the journey ahead.
Mia, very briefly, your closing comments on some of the quick wins that can be implemented.
I think if we want a proper integrated health system, we need an electronic health system in this country that we really only have on a very small scale at the moment. That means that if a patient in Mpumalanga has an antiretroviral drugs and go to Gauteng, there must be a system that tracks that patient and also says on what other chronic medication that patient is. And at the moment, we rely on pieces of paper. And I think we are trying to implement a system, but it's still on a very small scale, and it's very hard to integrate that healthcare and to track patients, and not to have a patient from Mpumalanga having to undergo all the tests that they underwent when they go to Gauteng. I think that will bring us a long way.
Ntutule, very briefly, your perspective on some of the quick wins?
Yeah, I think just on the study side of things, in igniting, these discussions and so forth, I think this is the first Future Health Index study that we have done. We would like, obviously it's an annual study that we will be doing, so every year we will have something like this, and I think a lot of input has been coming out of here in terms of addressing the 3 critical issues that we have put forward when we started with the study, issues of access, issues of integration, and then issues of connected care. But I think also, just if I may add, I think the issue of co-creating solutions among this triple P is really very, very important. As the minister was saying, it appears that now we've got 2 countries in one in terms of the systems, and I think we need those efforts to make sure that we bridge that gap. So that I think we can all play and contribute towards.
Honourable Minister, very briefly, your closing remarks, and also in bearing in mind the 2 questions that were also raised regarding occupational workers.
Firstly, I want to emphasize once more, which becomes very unfortunate every time there's a debate. NHI is not a beauty contest between the public and the private sector. It's a way to use both of them for the benefit of the population. That's what we want to do. The second thing, Mia, let me put your fears to rest. The issue of a health information system to integrate is one of the 6 building blocks of a healthcare system by the World Organization. We've been working with CSIR for the past 3 to 5 years on this issue. We've already started implementing. In the NHI, the 10 NHI pilot districts, we've already put up the system in 657 clinics. In April this year, we took 1,400 clinics. We will have completed the system at the end of the financial year 2017-2018. Meaning what? Meaning if you go to a clinic today and get treatment, and tomorrow you decide to go to another clinic demanding the same treatment, they will tell you exactly what you got yesterday, where, at what time. That's what we are missing in the system today. But we are busy implementing it. By 2017-18, the whole healthcare system will be having that I promise. Thank you.
Very briefly, we'll leave it there, though, Minister, on the occupational workers, and we'll perhaps attend to that question offline. Thank you so much to each of my panelists for participating in this conversation, together with the audience members who asked questions. Clearly, it's a very robust conversation and difficult questions and answers that need to be addressed between both the public and private sector participants in the healthcare fraternity as we try to make our way forward to a future of an integrated and connected healthcare system in South Africa and on the continent and beyond. But for myself and the team here at CNBC Africa, thank you so much for joining us for this Philips Dialogue on the Future Healthcare Index. It's goodbye for now.